Hi, everyone. Thank you for tuning in to the first career development webinar hosted by the SSR Research Committee. My name is Erin Alaia. I'm a musculoskeletal radiologist at NYU and chair of the SSR Research Committee. The focus of our webinar tonight will be research funding for physician scientists. Grant funding is a monumentous and sometimes overwhelming goal for many academic MSK radiologists. Within our society, we're fortunate to have several members who have obtained funding through some of the most competitive grants that are out there. We can learn a great deal from our colleagues. Tonight, we have 3 grant-funded musculoskeletal radiologists that we all know because they're leaders in our field. First, we have Dr. Christine Chung, our featured speaker, who will give a talk on grant funding for physician scientists. Dr. Christine Chung is professor of radiology and the executive vice chairperson at the University of California, San Diego. She's a grant-funded clinical translational researcher and the director of the UC San Diego's MSK Imaging Research Group. She has successfully mentored undergraduate students, medical students, radiology residents, radiology fellows, postdoc candidates, as well as junior faculty. She has more than 200 peer-reviewed manuscripts in scientific journals. She's edited 4 MSK radiology textbooks. Dr. Chung was recognized for her excellence in research and was awarded the President's Medal of the ISS. She has a long history of grant funding through the VA as well as the NIH. She received the prestigious Distinguished Investigator Award from the Academy of Radiology and Biomedical Imaging Research, a distinction bestowed upon MD, PhD, or MD, PhD candidates within the field of radiology, ranking within the top 10% of all academic faculty. Dr. Chung's research interests lie in the application of novel MRI pulse sequences for the characterization of musculoskeletal tissues. She and her lab group have done extensive work in the evaluation of short and ultra-short T2 tissues in the MSK system. This includes, among other things, articular cartilage, the temporomandibular joint, the knee menisci, as well as cortical bone. The group is focusing on quantitative MRI biomarkers that may serve as non-invasive references to biochemical integrity and function of tissue. Next, we have our panelists, including Dr. Miriam Bredella, professor of radiology at Harvard Medical School and a musculoskeletal radiologist at the Massachusetts General Hospital, where she serves as vice chair for faculty affairs and clinical operations and directs the MGH-wide Center for Faculty Development. She's an NIH-funded physician scientist focusing on using novel functional imaging techniques to determine the effects of different fat depots on bone and metabolic risk in states of under and overnutrition. She's the principal investigator of the NIH-funded Harvard KL2 Catalyst Medical Research Investigator Training Program, where she oversees the career development of clinical translational researchers across all Harvard hospitals and specialties. And next we have Dr. Eric Chang, a staff physician at the VA San Diego healthcare system and professor of radiology at the University of California, San Diego. He's a clinician scientist with grant funding from the VA, NIH, as well as the Department of Defense. His research focuses on refinement and translation of novel imaging techniques with a focus on quantitative MRI and ultrasound. He's the director of the VA and Veterans Medical Research Foundation Microimaging Core, which provides histology and microimaging services to the regional community. So first, we'll start with our talk from Dr. Chung.
Hi, everybody. Thanks to the SSR for organizing this and for allowing us to talk a little bit about building a research career as a physician scientist. I'm going to hopefully get acquainted with how I'm going to advance my slides, first of all. But start off with my research journey line and move through a few slides, and then we'll have some discussion with Miriam and Eric. And I think that's kind of the best way to figure out the insider tricks of the trade with respect to research and how people kind of did things. So if we look at my career starting from fellowship, I had a super heavy first 5 clinical years, and the first 5 years of your career are really considered the research development years. And part of the reason for that is because that's the period of time when you have access to a lot of career development grants. And some of those mechanisms are really desirable. I kind of squeaked in right at the 5th year. And I think there was an advantage and a disadvantage to that. And we'll emphasize these points later. But because my first 5 years were so heavy from the clinical standpoint, I think I really understood the challenges that were opportunities to address from a research standpoint. So at year 5, I got one of those career development awards, the RSNA Scholar Award, and that kind of changed my whole professional life. So it gave me 50% funding or support off the clinical schedule for 2 years. And so I was really able to prepare my first big grant, which I did. I got preliminary studies for an RO1. And through this period of time, I sought out the advice of several experts in the field in my institution. And it was sort of depressing because one of the senior PIs that I talked to, a very, very well-known kind of luminary in the field of cartilage evaluation, not in imaging, but cartilage, said I would never get funding in cartilage and I would not be able to have a research career if I sought to do that. So that was kind of depressing. However, it was really what I wanted to do. So I essentially tried it anyway. I submitted my first NIH grant, and that's a huge, huge success and accomplishment that should be celebrated by itself, whether or not it gets discussed or funded. And when the review came back, it was sort of demoralizing again, because that review said, this person is a very well-known clinician and educator, and she should probably stay clinical. Okay, well, so that was a little bit depressing for a minute or two. And then I thought, but I really want to do this. I have to figure out how to get my foot in the door. And maybe it's not through articular cartilage. So I poked around. I was lucky enough to be able to, with this RSNA Scholar grant, also have a lab manager. I'm going to mention her name, Sharonda Statham, because she was my partner in crime through my whole early career. And together we were really able to do so much work without a lot of infrastructure. And ultimately, we got our foot in the door through NIH funding through looking at the TMJ, so not classic articular cartilage. And then from there, I was able to write other grants that dealt with cartilage and osteoarthrosis and got funding through the VA and the NIH, and on and on and on. And there were a lot of low points in here, which I didn't stress because really we're talking about early research. And so the process, it was sort of organic, but it certainly could have been facilitated by having somebody who had a knowledge of all of these steps in this process to help me out a little bit. And while I had mentors, I didn't really have mentors that were well versed in grant funding specifically. And so through the retrospectoscope, as I think about research funding, scholarly output is important. You have to have a record before people are really going to consider your grant applications very seriously. You have to have domain expertise in order to be able to help you identify the problems that you want to look at. And then you're trying to build this trajectory of escalating grant funding. So that trajectory for me, the first big step was into one of those professional society grants and then on to NIH and VA. But small intramural grants are usually where people start to show, one, that you know and have gone through the steps of writing a grant, and then you move towards these society grants and get bigger and bigger. And there's a little money associated with all of these smaller grants, and that increases with the level of the funding source, and you're getting preliminary studies as well, money for preliminary studies and producing things, as well as, you know, creating this track record of, again, a trajectory of escalating grant funding. Your scholarly output, again, is important for all of these steps. So as you're doing this, it's also important for you to have an understanding about the targets that you need to meet in your own institution, because you're doing these things in parallel. You're trying to get grant funding, but you also want to know how that fits into your home institution. So domain expertise is again, a key component. Mastery here is one of the key words that I like to emphasize, and it's a comprehensive knowledge or skill in a particular subject. So you need to decide what it is you are going to be the domain expert of, because generally it falls into place then that that's what you're going to want to write about. Those are the things you should have passion for, you should love to do, you want to do. You become this domain expert, and your grant writing, it becomes a natural, I think, again, organic follow-up of whatever it is that you're doing. You do have to curate your brand with regard to getting grants, applying for grants, because part of this is your reputation. So you want to build your community, whatever that might be. Maybe it's going to be Rank and Ray, maybe it's going to be radiology, ISMRM. It depends what kind of interest you have, what your domain expertise is, what your passion is, and what you're going to target for grants. So pick societies and curate your brand. Present material at these meetings. People will come to know you. Study sections have a broad range of people, and it helps if you have a reputation for being known as this domain expert and being a good educator and researcher. Committee service is also how you get to network both within your institution. You never know who you're going to meet from multidisciplinary study section at your own institution, as well as at all these societies, because a lot of these folks who are in leadership and at these meetings also stood on study sections. So you'll get to know them, and they'll know who you are and your reputation. So that's important. Again, this idea of moving back and forth between your brand, your career development with grant funding, and what it is that you need to do with regard to your career development. Now, grants are important for career development, but at our institution and at many academic institutions, the coin of the realm isn't necessarily the grant funding. It's expected that you're going to have some grant funding. The coin of the realm is the scholarly activity. So if you get millions and millions of dollars of grants, but you never write a paper, you're probably going to have trouble getting more grants, number one. And number two, you're going to have trouble advancing in your institution. As you're getting preliminary results, you're going to write and present. And certainly as you move through your grant funding periods, you have to have scholarly activity. And when you're junior and in those career development years, you have to get independence. That means your own ideas and you being first or senior author on papers, ultimately without your mentor. So again, this trajectory of escalating grant funding, 5 years post-training, the intramural, the professional society, and then moving after that towards things like the K Award, excuse me, and NIH funding, the R mechanism, R01, DoD grants. So those bigger grants that generally you're looking at 3-4 years, and not just a 50% effort, but you're looking for things that are $100,000, $150,000, even $250,000 of funding per year. Those are the mechanisms that you're looking to target with that escalating pattern. So as you're building your career and you're doing all these things to build the research component, don't forget to check in with you, and that should happen fairly often. It helps you to make sure that you're kind of on track, both personally and professionally, and you have to have a balance there. It's extremely difficult, I know, especially in these times of high stress and anxiety for many, many reasons, socially and professionally, to maintain this, but you have to think about it. And the other thing is really checking in helps you to figure out, where you are and where you want to go. And that might change too. When you start to work on grants and papers and you're doing your clinical work and you're teaching, you're so focused on these tasks that you kind of lose track of the big picture. So take a step back, figure out where you are, reassess, make sure your true north is really your true north and you're not going to make a change, and make sure that all those things are still satisfying you and making you happy. You have to really think about those things in order to identify things that are within your power to change. And you can always make a change. It's never too late. So don't forget that. Care for your most important resource. And of course, that is you, your most important human resource. As you're thinking about your career, think about it like driving your car. You've got your rear view mirror and it's small for a reason. So you can look and see what you did. And the reason you want to do that is to, one, celebrate the accomplishments, and two, try to make sure you don't make those mistakes again, but you're going forward. So again, check in and figure out what that direction is and that you're still kind of on the right track or where you want to be. As you're thinking about your research career, make sure that you curate the right tool set. And that might be a suite of tools that something like NCLAM, we have NCLAM here, a National Center of Leadership in Academic Medicine. It's a whole program that goes through statistics, how to do IRBs, all of these different things. Those are probably available, similar programs at every single institution. And maybe you need some very specific tool that you need to curate, but figure that out and find out how to get that skill set kind of in your back pocket. And then don't forget about leadership tools as well. We're not formally trained to be leaders in our medical field. We're supposed to be great doctors, and organically we're supposed to figure out how to do research. And then ultimately, I guess at some point, we're supposed to have as our primary success parameter to be some sort of leader, a chair, a dean, a division chief, but we're never really taught how to do it. So as you're thinking about moving through this career development and curating research tools, also leadership and communication, you want to have good open lines of communication with your collaborators. That helps to have healthy relationships and really, again, make sure that you can get as much as possible out of all parts of your research. So really important for you to consider all of these different things with regard to your career in general. And then you have to have some grit through the whole thing, because you're going to have to deal with rejection through the course of, again, curating this research component of your career. So anything that's hard is going to have successes and it's going to have failures. And so when you're having a rejection, you feel sorry for yourself for a minute or two, and then think about it like an opportunity. Break it down, analyze it, and then figure out how you can redirect and what you can gain from that experience, because generally there's something to take away that can help you move in a different direction and hone your skills in a different way. So if you kind of repackage it like an opportunity and not necessarily completely like a rejection, sometimes that's helpful, and certainly it's a learning experience. Make sure to be able to find your mentors, your sponsors, your connectors, your informational powerhouses. These are people that you need to talk to. Again, it's really easy to get focused and working, and that's all you're doing. And then you realize, oh my gosh, I need this, or I wish that I knew somebody who could help me with that. So curate again those people and relationships, talk to people, see what they're going through. It's going to help you as well. Learn from other people's experiences and figure out how they've done something, because it may be in a very different way that's more efficient or creative that could help you on your pathway. So while there's a tendency to put your head down and really just focus on work, 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 you also have to really be aware of creating this network of people. So this whole exercise begins with an important discussion with you. And again, this idea of the domain expertise and where does your passion lie? Check in with yourself. What do you want to do? Can you imagine doing whatever this is for 30 years, every day from 8 to 5 p.m.? I don't know. I mean, I have to tell you, my academic career with a mixture of clinical work and research and teaching and now some administration allowed me to reinvent myself 2 or 3, maybe even 4 times, and still to keep the best pieces of the things that I love to do. So this is a journey, it's not a destination. That's why you don't have to feel so much pressure to do things in such a timely fashion. There are some general rules of thumbs and opportunity, but if you're aware of those things, you can take advantage of them and enjoy yourself along the way. So that's really a quick, 10-minute discussion of, Mike, I'm done. You can take the PowerPoint down. A quick 10-minute discussion of kind of my trajectory through building a research career. And we thought we'd use that as kind of a jumping off point to talk with Miriam and Eric, because they're both super, super accomplished researchers and physician scientists in the field, and see what kind of pointers they have for us. So feel free to throw questions into the chat. And I think Erin has some questions maybe from the SSR group that we might be able to start with.
So I thought this was a good question. How do you get a sense if an idea is reasonably fundable before pursuing it?
Well, I can talk about that. So it depends for what kind of funding you are looking at. For example, if you're going the NIH route, then what you can always do is contact your program officer. So each institute from the NIH, they have something on imaging, they have one on endocrine, cardiovascular, aging, cancer, the NCI. They have program officers, so you can always contact them. They typically say, sure, why don't you submit it? But often it is actually helpful to get their input. But before, if you're not really sure whether that's something you should do, like a step before, do a literature search, talk to your mentors, talk to other experts, not necessarily in radiology, but if you're doing something that has orthopedics or so, go there and talk to people in other fields and say, is that actually an important problem? Because the main part of an NIH grant is the significance. And if you have the best research plan and the best people, but you have a topic that is not significant, you will not get it funded.
Yeah, I think usually if you're excited about a topic, then someone else can be too. And it's just a matter of presentation and grantsmanship. As Miriam said, it never hurts to talk with your mentor and other experienced colleagues just to get a reality check that the agency might want to put money towards that.
I put a few things in the chat, Erin. So Miriam mentioned several of the funding agencies and their program officers. They list their phone numbers, their emails. And so if you have an idea, you can actually email these people, and they're incredibly receptive to having an email. They'll set up a phone call with you. You can talk about an idea. You can also look at published RFAs. They usually put RFA requests for abstracts or program announcements or roadmaps that kind of show the type of things that they're interested in. So poke around on the NIH websites, which gives you a lot of, I think, insights into those things. And don't be afraid to call. I think that's one thing people sometimes, they're hesitant to do it or don't want to do it. Isn't that your experience, Miriam and Eric? You can cold call and email these people, and they're so happy to talk to you.
Totally on top of stuff. I completely agree.
And
yeah,
even, go ahead, Eric.
Yeah. Oh yeah, for them to have longevity, I mean, they need to kind of cultivate these relationships in the field, and they want to hear from you and get the best from you.
Yeah, and they have what they call their portfolio of the things that they're going to fund. So they'll have like, I would like something in imaging or this or that or whatever. And they like to have relationships with the different investigators. They'll even go to the extent of, you could say, like, could I show you my aims to see if it's something that sounds right? And they'll say, of course, you can send the aims, because they're not the people that are judging your science. They're taking a look at the programmatic fit. So use that resource to your absolute, highest advantage.
I put something in the chat, two things. One is just the study section, so you see like what they are, but the other one is the NIH reporter, which I found extremely helpful, because you can put in keywords about, well, first of all, you can look up people, see what kind of grants they have, your institutions, but then you can put in the keyword weight loss surgery, bariatric surgery, and you see what is funded currently. Because another thing is, if there are already 20 grants that are dealing with the same thing, maybe think about a different topic. But I find the NIH reporter really helpful.
Yeah.
Thank you. Another question that came in: how do you become better at generating fundable research ideas?
Secret sauce, huh?
$1 question. We all want to know how. And I can tell you, as Christine, there is a lot of rejection in going the research route. And I currently, I'm really lucky. I have 3 R01 grants as a PI and 2 other grants. But for each R01 grant I submit, there are probably, or that I get, I submit maybe 3 or 4. Some don't even get discussed, and some where I thought these are really strong grants, and I personally feel that they're really good, they don't even get discussed. So that's, I was like, but then others where I think, they get funded. So I think it's the volume, and often you don't know what the study section likes and not. And I can just tell one story for the reason R1 grant we got. It's on actually liver imaging, so I'm branching out in other body parts. But we submitted it and it was not discussed. So not discussed means like you don't even get a score. It's like the lowest of the lowest. You get a
Well, it's not the lowest of the lowest. Now, come on, the lowest 50%.
Okay, fine, but you don't know which one. Maybe it was the
Well,
lowest.
maybe,
You don't know.
maybe.
You don't know. And so you get the reviews from the reviewers, but you don't really get, there was no discussion, so it's not really helpful. So then we submitted it again, and really it wasn't discussed. And then after 2 times, you have to resubmit a new grant. Of course, you can submit the same thing again, but it goes in as a new grant. So on the 3rd time, we submitted it again, not discussed. And then I said, forget it, we're not going to submit it again. But then my co-PI said, no, let's do it again. 4th time and got funded. So you just have to be resilient and you cannot take it personal. You just move on. And when I submit a grant, I already start collecting new data because I think it's probably not going to go in the first time. I have to resubmit. So let's just collect some preliminary data.
Yeah.
Yeah, I agree. In general, I find that clinicians don't really have too much difficulty at coming up with good research ideas. I mean, you're out there, it's important from the patient and the clinician's perspective. And so it's more of an idea, it's more of a problem of matching your idea with the right funding agency and then packaging it up with good grantsmanship. And obviously, statistically, you're not going to get funded. You have to try like 3 times at least to get that funded one statistically. And so I would recommend working together with somebody who's been successful at funding, so just to help maximize your return to effort. Because if you have to submit this thing like 8 times, it's kind of painful. So you want it to be like looking good on the first try.
We have a question from Dr. Aman Kodarami. He says, this is a good question. If your research is translational, such as novel imaging techniques that Dr. Chung mentioned, you'll have to compete with non-clinician PhDs. How do the panelists think we could improve our chances as clinicians in this competition for NIH grants?
I have some thoughts. Eric, Miriam, do you want to go ahead first?
What helped me, maybe I don't do the super novel techniques, but I was very successful in partnering with clinicians. I work with endocrinologists, so we go in as co-PIs and have an important question. So for example, we are giving oxytocin in children with obesity. It has really nothing to do with musculoskeletal imaging. But then I say, wow, why don't we look at hypothalamic inflammation and look how it influences appetite. So although maybe the hypothalamic inflammation is novel, probably not novel enough to get the grant. We also do some body composition, but partnering with someone who has a good clinician, who has a good clinical question, makes your research, your imaging, then elevates it to a different level. So it's nice to have the symbiosis with a clinical person and you as the radiologist. I think you can, and then you can apply also to other institutes, for example, the NIDDK, which is the diabetes and obesity kidney. They love imaging, but if you go in as a radiologist only with imaging, you probably need a clinician to work with you.
Yeah. Eric, do you have some thoughts?
You can go ahead. You go first.
I was going to say the same thing. Miriam, what Miriam pointed out is it's always great to have a partner on the clinical side. From the standpoint of the sort of clearly, like singularly technical, I think that's kind of gone out of vogue at NIH anyway. This idea of technique for technique's sake does not exist anymore. There has to be a clinical translational component. So from the standpoint of the novel sequences, they really need that clinical driver. And I think that's where the clinical component is so valuable with respect to applying these novel sequences. And the other thing is to really understand, like when you're looking at a lot of the quantitative sequences, you do every day when you're looking at images, kind of this semi-quantitative evaluation. Your eyes are kind of making this grayscale estimation of quantification that when you start to look at numbers, you can say, geez, that doesn't make sense and that doesn't make sense, which the PhDs don't really know because they don't understand the visual component of it. So I think it's hugely valuable to have that partnership of physician scientist and basic scientist, and then the referring clinical person also. And then target your grants to places that, you know, are primarily clinical, but have this really novel imaging piece to it. I mean, it's that marriage and partnership, I think, is so valuable, and it's in and of itself considered kind of a novelty for a lot of funding agencies to have that powerful teamwork.
Yeah, I mean, I kind of echo what you guys have just said. I mean, it's a team of individuals, and so, you know, if you're going in as a PI, you know, as long as your co-investigator, who might be that PhD, is vested in this project and you're qualified to be the PI, they're not going to come back and be like, oh, why is that co-investigator not the PI? You know, and if that's critique, you could always go in as co-PIs or something. But that would be distinctly unusual. But you need everybody on the team, and you know, you're going to have a role that's different than the PhD, just by the nature of what your expertise is.
And I think, you know, Eric brings up a good point here. Part of being successful in your grant funding is to show that you, not necessarily that you're an expert in every one of these things, but you've assembled the appropriate team to deal with everything you need. So if you're not great at biostats, you've got a biostatistician. If, you know, you need a basic scientist physicist, then you have that person on your team. You know, for post-image processing, you've got a way to, so you have to just explain, how am I going to get these things done? This is all my idea. I'm collating all these things and bringing it together, and just show that you have the expertise.
We also have a question from Paul Yee. He's asking, how much prelim data is enough for a competitive R01 application? I've been advised you need prelim data for every section aim. Is this a practical absolute, or are there caveats? For example, if the last aim is somewhat exploratory in nature.
I think sometimes you have to sometimes they require to have done the study already before you apply. So yeah, I agree with the statement that you have to have preliminary data for each aim. How extensive they are, it's a sort of a fine line. Reviewers, if it's something novel, they want to make sure before they give you your $2.5 million or whatever, that it's something that will work. So you have to show some preliminary data, and if it's something that's more established, maybe you don't need as much. And for exploratory aims, it's not that critical, but for the others, you definitely want to have very solid preliminary data. And it doesn't have to be exactly all novel. If you have written papers, you can always say it doesn't have to be yours, but you can say our group has shown previously that blah, 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 and then you can add that in. But yeah, prelim data are.
Yeah, I mean, in general, they say that the prelim data is just to support the feasibility of the project, but this, how much you want to show is going to depend on which grant you're trying to write. I mean, if you're trying to write like an R21, you know, you're not going to have the same. You know, there's some small grants that they don't even want you to have too much prelim data. But in general, prelim data is just to show that you're going to be successful, and obviously. The difficulty of getting this is going to depend on what kind of research you're engaged in. You know, there's going to be some things that you can't do without having the resources. And so, you know, in that scenario, it's going to be hard to know how the reviewer is going to critique you. And, you know, you just, in general, do the best you possibly can with the resources you have. And if it slides through, great. And if not, then just go from there.
Also important, you know, don't have too much of your preliminary data as though you've completed the whole study, because then it's like, why are we giving you money? You've done the whole study. So it's this balancing of just enough to show proof of concept that you can do it, and that there's a high likelihood that your hypothesis will be correct. And then you also have to be a little careful about what you're presenting at meetings and publishing, because you know, people do, you know, subconsciously, you know, see ideas and then start working on similar things. And, you know, so just have to be a little bit careful about how your timeline, your packaging, and what you're presenting moves forward.
I have a question. How do you, achieve grant funding with a heavy clinical load? How do you keep work-life balance? How do you maintain everything?
The heavy clinical load, I think, is a good question. So I'd be interested to hear everyone's opinions on that myself. Like, what is the right amount of clinical work starting off? And how much clinical work do you think you can do and be able to write a grant? I know I've got my idea. Miriam and Eric, what do you think?
Well, when I started, similar to you, I started full-time clinical, and then I wrote I started with a K award, K23, and I wrote it while I was on clinical and pregnant, and I think I submitted my K, had a baby, got married, bought our first house, all within like 2 months. So it was a very busy time, but then it paid off because the K award it requires you to be 75% on research. So you can only do 1 day clinical. And that's why I started this after being 1 year as faculty, which I think is sort of on the lower side. It probably might have been better to be a little bit longer full-time clinical, but it was 1 year. It was like about 1 year, little less. And then I was 1 day clinical. And I have been this ever since. But the nice thing with the K23 is you get this 1 grant and you are good for 5 years. Then when you have an R01, you cannot put 75% of your salary in R01 because then the budget is gone. Then you need about 2 or 3 grants then to maintain that level. So I think there was for a short time, I was a little, but you don't have to be the PI of all the grants. But if you want to support yourself, you can be a co-investigator on someone else's grant, 10% here, 5% there. Then you have your 20% on your own grants. And that's how you then patchwork your research time together. But I've always been 1 day clinical since, I don't know when I got my 2006, 2007. And I take call with everyone, like everyone else, which is always good because I see a lot of cases and I do procedures. But that's, I hope it worked for me. I have to ask my colleagues whether that's enough or not, but no major misses or complications.
Yeah, I think it's hard to have a balance. I mean, this is going to be something you're going to have to tackle for like the rest of your whole life. I mean, finding this balance and reestablishing the balance, making sure that, are you in a good place in your current balance? But for those that are starting that off at 100% clinical, the nature of this piece is that you're going to do nights and weekends to get yourself that grant and get these resources. And then you're kind of buying yourself some time off the clinical schedule. But you have to start somewhere, and unfortunately, if you have a heavy clinical burden, then all of this research stuff gets shifted into your own personal time. But hopefully, if you're ready for it and you can embrace this and then kind of get yourself grant funded, and then that time kind of builds on itself.
Yeah, I think it's tough. So you want to be, again, you have to be sure that you're kind of dialing in mastery of your domain expertise, right? So you want to have exposure to clinical work. I think you need a day, 2 days, really a week, 1 day for sure, and preferably 2 when you're like 2nd, 3rd, 4th year, to be able to have time to meet with people. So that day has to be reproducible, because this team that you're working with, you have to be able to meet with them. You have to be able to do experiments. You have to be able to have a schedule. So I think that's really important. It's not an absolute, but it's like sort of an ideal, something to strive for and to ask your chair for, or supervisors wherever you're working, if that can be done. I mean, if you're preparing for an NIH grant and the outcome metric, your deliverable is the grant, in many cases, departments will do that for you. They'll give you a year where you might have an extra day off or a day off. So that reproducible nature, to be able to, again, meet with people and get things done on your schedule, is important. And then the other thing for me, when I was like super busy for those like 4 or 5 years, my mind was so busy every day, like going from the clinical to this to that, that my creative output was definitely not super high. I used to worry, like, what if I don't have any ideas? Like, I'm not going to have any ideas. I'm not going to be able to write any grants because I don't have any ideas. But then after I was less busy clinically, then it's like, you know, and Eric and I laugh about this. We can't stop having ideas. We're constantly having, everything's an idea because, you know, you have time to think about things and, you know, look at stuff, and you have to be, your brain has to have a little relaxation time in there to, I think, really be able to have creative thought. So that's my 2 cents worth.
I'm glad you said that because I'm in the phase where I struggle with ideas. That makes me feel better. Another good question from the research committee. How do you identify, what do you look for in a good clinical collaborator?
Well, I think especially if you're starting out, it's great to find someone who is experienced in grant writing. I was very lucky. I was hooked up with a group that was extremely experienced and very successful. And I felt more like a sort of a parasite, sort of hopping on to them. So one person was writing the R01. I did the same project, writing a K, and then put the imaging in. And then at one point, you see, you feel, you breathe, you hear about it all the time, how they're doing things. And I was told, well, once you have your first grant, the K, you already have to start thinking about the next one. And you can, now that you're doing your K, already start thinking about the next grant and get preliminary data for the next grant while you're getting the patients in for your own. So all these things, it's really nice to have someone experienced. You don't have to. Christine said she was like on her own in the beginning. I was very lucky to be in a group. So if you're looking for a collaborator, it's nice if it's someone who is established, but if not, I would really make sure that they have this. You send them an email, they're on top of it. They are their attention to detail, I think, is key, very thorough. And these are just a couple of things, but if they have a proven track record, that's even better. I don't know, Eric, Christine.
Yeah, so like full disclosure, I mean, I had the benefit of having Christine as my mentor, so things were a whole lot easier for me. But as far as what I would give for advice, you'd obviously start with finding, just talking with the mentor if you have one, or maybe some other senior investigators. Like often it's not, it's what you don't know that's the most important, and that could be like who not to work with, or which particular person on a senior collaborator's team is like the workhorse person that you should be spending more time with. You know, it would be ideal if you learned from others, like which senior collaborator is good, and then meet with them, get them excited, and also obtain their support. Well, the one thing to keep in mind is that these other investigators are looking for good radiological or imaging experts and collaborators, and so you know, they're looking for you as well, and so that's something to keep in mind.
One thing I would just add to that, from the standpoint of mentors, collaborators, clinical collaborators, sometimes you just don't know, and it's kind of a crapshoot. You're trying it out, but you can have some control over it, and at least I think some confidence is you sort of take the lead with communication. So it's really crucial to have very straightforward communication, like what role, you know, will people have? What are the expectations? You know, who is producing this? Who will, I mean, be a PI or a co-PI on papers? Who will be the authors first, second, last? In granting, if you're co-PIs, who's going to get the indirect cost, which department? All those like things have to be really discussed and not just assumed, because what will happen is you're going to assume, well, clearly I'm going to get those indirects, and the other person is assuming the same thing, and then you have, you know, a problem with the collaboration that wouldn't have had to have happened if you would have just directly addressed it in the beginning. So really ask a lot of questions and openly communicate about things, because that's key to not having, you know, problems with those relationships moving forward.
Thank you. We're almost up to the 45-minute mark. Do any of the panelists have any final thoughts?
Well, I have to say, I like the freedom also in, I don't think the women own, I'm sure there was men who take care of their children, but I found having no family here, husband who travels all the time, having this, having the research, you're never done. There's always something every night you will work, and on the weekends, always something creeps into your in your private life. But I really, really value the flexibility. I know when I'm an academic and there is something with my kids, I can just go, or I can go to the recital and then I just work later. So I love the research and the flexibility. That's just another point of view.
Yeah, I think having like, you know, every hour being different, every day being different. I mean, it's so stimulating, and you know, you just run into so many different interesting people, interesting projects. I mean, there's no end to how many cool things you can be involved in, and so you just need to get started, and then you know, every day is different. I mean, it's not like you're dragging yourself in. It's like you don't. It's very, you know, experiments are going to yield all kinds of different results.
Yeah, I totally agree. I mean, the flexibility is huge. I mean, just being able to go to work every day and have some sort of question and being able to answer it is amazing, right? I mean, you just get to talk to other people who are interested in things as well. You get to, you know, solve problems. It's just, I mean, it's incredibly satisfying, and it's a really fun part. I mean, you know, I think all of us feel it's a fun part of our job as well as a challenging part of our job, and it brings immense satisfaction. Like it's one of the best things that I do.
Thank you so much. And thanks to everyone in the audience for tuning in tonight. Thank you especially to Dr. Chung, who took time out of her busy schedule to prepare this talk. You organized an amazing panel of speakers. Thank you to our amazing panelists for a great discussion. Hope to see you all soon at a future SSR webinar.
Yeah. Thanks, everybody. Thanks, Miriam. Thanks, Eric. Bye.
Thank you.
Bye.
Bye.